My name is Robert Pollock, and this is the SP reflection for the knee evaluation patient. So overall, I thought the knee evaluation patient went really well. I finally felt like I was a competent clinician, and the fact that I was able to pretty much perform the evaluation systematically and provide adequate adaptations for the patient so that they can continue to do their activities of daily living while also seeking treatment and seeking further medical attention. So the first thing that I thought was really apparent as one of my strengths was that I was patient-centered in my care. So, for example, one of the questions that I asked was, hey, do you have trouble sleeping? Did you have trouble sleeping last night? Do you notice this during walking, climbing stairs, etc.? And from this information, I got a lot. So he had not been sleeping that night, and he noticed it was stairs, which was a little bit of a red flag for meniscus, but he also had a lot of instability just in general standing on it. That was very apparent in the functional assessment that I did, just having him stand on it, trying to do squats, etc. Another thing that I think went really well is that I took a very detailed history. So, for example, I took the patient information, your pain, where's it at, localization, does it shoot, does it seem like it goes other places, can you point to it with one finger? And pointing to it with one finger was really helpful because when he pointed more at the MCL than his meniscus. And that kind of also gave me a red flag. Well, maybe it could be both. And maybe it's not so much the meniscus that's the problem, but the MCL instability that's the problem. Then I did do a couple things that I feel like I need to improve on. One of that would be that I completely neglected the pain intensity portion of it. So I never asked, what's your pain at right now? What's the pain scale? As a baseline, what was it when it happened, which in retrospect really didn't hurt my evaluation per se on this one, but in the future could be a really big, determination of, okay, it's not this pathology, it's this one. The other thing that I didn't do was I was suspecting the unhappy trio as one of those three to be the pathology, either an ACL, an MCL, or the meniscus. And I neglected to palpate the hamstring tendons. So, again, it didn't hurt this evaluation as much, but if it was an ACL, then if they were guarding with their hamstrings, it would have been really hard to get a positive either in that Lachman's that I did or the anterior drawer that I did. However, I don't think that was a key factor. I think that it would have been a nice thing to include just to make sure, but I don't think that it severely infected my evaluation. So, one of the things that I would take away from this after I watched, especially with a real patient, is that I seem to want to do the functional assessment. So I had them do the squat, try and do a tandem squat, and couldn't really move that much. And then I wanted to do Thessaly's for the meniscus and completely forgot that he could barely squat. So when I got him up to do Thessaly's, he ended up sitting right back down, and there was no information to gain from there other than he couldn't stand on it, which was already determined in the functional squat. The other thing is that although the patient was trained, I found myself prompting the patient to say, this is positive, this hurts. Especially in the McMurray's test, when I straightened the leg out on the positive side, I said, this causes a lot of pain, right? And he said yes. So maybe for a real patient, that would be a bad thing to do, and I shouldn't have done it. But at the same time, I felt that he probably didn't know if that was going to cause pain or not, so that's why I did it. I realized that it was a really bad decision, especially with a patient, like a real patient, and that's something that I'm going to completely scrap from an evaluation. I'll ask if he experiences any pain, or to tell him that I'm going to perform this test. If you experience any pain or hear anything, let me know while I'm doing it. Other than that, I believe that it was really apparent that I've grown a lot since the first standardized patient that I did, and I really feel that I'm a confident clinician now. Thank you.